I think we should be good to go now. So today's talk will be mainly on the fetal heart examination. I think when we asked pose questions on what people would want us to cover, there was a request that you should try to go through the fetal heart examination again. So this is exactly what we are going to do today. We're going to just go through the basics of fetal heart examination. Please take note that the reason why we go through these sessions over and over again is because we want everyone to achieve the competence. Fetal heart defects are the commonest defects you will find in the world, so that anyone who wants to examine a baby, someone's baby, should be competent to do a basic fetal heart examination. This is the reason why we have to go through this over and over again, so that the level of competency can be obtained. I'm going to go straight to my important slides since you are late. So the approach to the fetal heart examination is as shown here. That the first thing is that you should identify the rate and the rhythm. I think this is the first thing that we recommend that everyone should do before they even start scanning the patient. So the first thing is identify the rate and the rhythm. I'll come to the rhythm in terms of what we mean by rhythm. The next thing is identify the position of the heart. Is it normally positioned in the thorax? Then the next thing is identify situs, abdominal situs. You want to make sure that the aorta is to the left and the inferior vena cava is present, and to the right, and the stomach is where it should be. Then the next thing, we want to examine the four-chamber view, followed by the great artery view, that is the left outflow tract and the right outflow tract. The next thing, you want to do the arch views, which are the three vessel view and the three vessel trachea view. Then, of course, if you are doing an extended in fetal echo, then we are going to do the cardiac biometry and Dopplers. But today's talk will probably end at the three vessel view. We just want people to be competent in terms of screening the fetal heart conditions. So what are the common planes that we normally obtain? These are the common planes we normally obtain here. These are the common planes. You are familiar with this plane because you are all doing abdominal circumference. This is a very important plane, as you will see when I come explain the situs. The planes in the uterus, to get to the four-chamber view, all you have to do is to move in a straight line from the abdominal circumference plane. You are going to obtain the four-chamber view. If you just transition going up the baby in a straight line with your probe, of course, cutting across the baby's stomach, the abdominal circumference plane, you will encounter the left outflow tract. If you do rotate your probe upwards, the four-chamber view, if you do rotate your probe upwards, you will have the left outflow tract. That is, if you make a rotation of the right side of the probe, of the left side of the probe, you rotate left upwards, you are going to get the left outflow tract. If you do rotate your probe to the right, you are going to get the right outflow tract. If you transition upwards, if you move upwards in a straight line, you will encounter the three vessel view. If you continue to move again, you will see before you go to the three vessel view, you encounter the three vessel trachea view, then the three vessel view. It is important to understand a little bit of cardiac anatomy when you are doing the fetal heart examination. The baby's heart in uterus is positioned in such a way that the four-chamber view can easily be visualized with a transverse plane. We should also understand that between the aorta and the pulmonary artery, there is a communicating ductus arteriosus, which I will explain. Which probably most people who may have done just anatomy of an adult may not be aware of. But the ductus arteriosus is a very big vein in uterus, and we should all try to recognize it. I'll show you the ductus venosus as I proceed. My next slide is on heart rate examination. So to be able to examine the baby's heartbeats, it is important for people to know where to place the pulse wave gate. The ideal place to place the pulse wave gate, I know most people just look for something beating and you just place your probe there and you do the heart rate. But here I'm talking about the correct way of doing it. Say, what is the correct way of assessing a baby's heart rate? So that in addition to just counting the heart rate, you can also assess the rhythm, because the rhythm has to be assessed. Some babies will have tachycardia, some babies will have ectopic beats, some babies will have all sorts of rhythm abnormalities like supraventricular tachycardias, ventricular flutters, and arterial fibrillation. All these defects do exist in babies in the same manner that they do exist in adults. So where is the correct position to put your pulse wave gate? It is just below the valves. You can either put in within the tricuspid or within the mitral, below the tricuspid or below the mitral valves. So you put it inside the ventricle, just below, with your gate at 2 millimeters. That's the correct way for you to get this kind of tracing. The heart rate, I think we are all aware that it varies between 110 to 160. But the natural trend of the heart rate is that it is very high in early pregnancy and trends towards lower values towards 10. So that it is normal to see a 41-weeker having a heart rate of 112. But it is not normal for a 20-weeker to have a heartbeat of 112, or a 12-weeker baby to have a heartbeat of 112. That would be considered as low. So you need to understand this so that you do not have this arbitrary interpretation of the heart rate whereby you may miss defects because they are just too arbitrary. So if we check this heart tracing, where we are putting the probe in the right place, this is where it should be. I could have put it here also, just underneath the tricuspid valve. You guys have a point at all. I just want to check. So the right place is here, where there is a beating heart, underneath the tricuspid valve or underneath the mitral valve. But when you place it closer to the interventricular septum, so that you can capture both the inward and the outward What are you going to capture on the inward? You are going to capture the filling of the ventricles. Then on the outer part, you are going to capture the emptying of the ventricles. So in other words, you are going to capture both the arterial systole and the ventricular systole. The ventricular systole is what gives us the filling of the heart, of the ventricles. The arterial systole gives us the filling of the ventricles, while the ventricular systole gives us the emptying of the ventricles. So in other words, you are picking up both the actions of the sinoatrial node and the arterioventricular node. What is the sinoatrial node and the arterioventricular node? I'm no longer sure, but you capture both the electrical impulses generated by the atria and the ventricle. What are we trying to establish? We are trying to establish if indeed the beating of the heart is being regulated by the sinoatrial node. The sinoatrial node is found in the left-right atrium and is the one which generates the electrical impulses that gives the heart its beating. A normally functioning heart, the contractions or the electrical impulses should start at the sinoatrial node. Then through the Purkinje fibers and the atrioventricular node, it should then be transmitted to the ventricles. So in other words, the order of beating is that the atrials contract first, followed by the ventricles. And there should be evidence that there is coordination in those contractions. This is what we mean by rhythm. To say, is the rhythm a sinus rhythm? We're saying it's a sinus rhythm because we're saying it is originating from the sinoatrial node. This is very important to understand because some may have a background where nobody ever spoke about sinoatrial nodes and so forth. But for you to be able to comment on the sinus, on the rhythm, you need to understand these terms. So what do we have here? What you see, this biphasic waveform you see here, it will represent the sinoatrial or the arterial systole. So whenever you see this is arterial systole. What we see down here is the ventricular systole. So for us to say this is a sinus rhythm, we're saying every arterial systole is being followed by a ventricular systole. Arterial systole, ventricular systole, arterial systole, ventricular systole, arterial systole, ventricular systole, showing that the heart is conducting fibers by passing the electrical impulse to the atrium first, then followed by the ventricles. Atrium first, followed by the ventricles. That is the normal sinus rhythm. So today, as you scan, try to do it properly when you are checking the baby's heart and get the sinus rhythm. Because for you to be able to identify fetal arrhythmias, first of all, you need to know what is normal. If you don't know what is normal, you are going to take every fetal heart rate as normal, including where there is fetal tachycardia, where there are ectopic beats, where there are a lot of arrhythmias. We are not getting a lot of fetal arrhythmias in our fetal defects clinic. It doesn't mean that they are not there. It just means that we are missing them in the routine clinics or wherever people are being scanned, they are not being referred to us. So we want to improve the detection of fetal arrhythmias. So please, today when you are doing the fetal heart rate, zoom the heart enough and place the caliper below the AV valves, close to the IVS septum, the intraventricular septum, and you are going to get this kind of tracing. Look at it. See if every arterial contraction being followed by ventricle, every atria by ventricle, so that you know you are doing it the right way. As long as you are not doing the right way, it will appear as if our people do not have arrhythmias, yet we are missing them. So to go on, the other role of doing it properly, it will allow us to analyze the E and the A wave. If you look at the arterial waveform, it is biphasic. Why is it biphasic? It is biphasic because when the atrium contracts, it contracts in two phases. One phase is what we call passive contraction. The other one is called the active contraction. So the passive contraction, which just empty, it just happens without the heart being pushed too much. This is normally followed by the active one. The active contraction, the atria really contracts. This is why we have a biphasic waveform here. So the first contraction, or this first waveform, is called the E wave. That's the E wave. Then the A is active, which is the A wave, means active contraction, so that you remember it. So the E and the A wave. The E in the uterus should always be smaller than the A wave. If it reverses, it shows that there is a problem in the channels. Either there is an obstruction going on in the heart channels, in the flow of blood. So any baby who shows a higher E wave than the A wave, they have to be referred to the fetal defect screen for fetal echo. So the E wave should always be smaller than the A wave. Please remember this, because if you don't remember it, we will not improve the detection of babies whose hearts are not okay. It's only in very late third trimester that the E and the A wave may get fused, or the E wave may be of the same height as the A wave, or may slightly overtake it. We're talking of late third trimester. Why late third trimester? Because extrauterine, if we are to do everyone's heart who is in this meeting, the E wave is taller than the A wave. So this is only an intrauterine situation. Extrauterine, the situation reverses. So extrauterine, the E wave becomes taller than the A wave. That is normal, because there are no more shunts, there's more low pressure issues in uterus. So the E wave is the one that really pushes most of the blood into the ventricle, followed by the A wave to squeeze it all out. So the E wave has a higher velocity than the A wave, extrauterine. So there is more information you can get from the heart rhythm rather than the rate. And we want you to perform at the level we are describing here, because as long as you cannot perform at this level, we are not different from people who are doing screening scans. We continue to miss cardiac arrhythmias, which is happening at the moment, where we are not picking up cardiac arrhythmias. We don't see lots of them. We see them here and there, but in the majority of the cases, we miss them. What else can we do with this image? With this image, it allows us to calculate the arterial rate. So if we want to know the rate, to say what rate are the atria beating at, we are going to measure. As you can see, we measured here. These biphasic are the ones we measure for arterial rate. So you can see that the arterial rate is 140. Then we can also calculate the ventricular rate, because these downwards here, they represent ventricular systole, right? So we can see we have calculated here the ventricular rate using this ventricular waveforms. So you can see it was 140 here, the ventricular rate. Very important, because we're coming to abnormal arrhythmias, I think, the next slide, so that you realize how important it is to do a fetal heart rate properly. So there is a lot of information we can obtain just from doing a fetal heart rate about the baby's heart. Right, there we go now. Now we have gone, we have described the normal. Anyone who wants to tell me what is wrong with the two arrhythmias we are looking at there, with the two heartbeats we are looking at, which is different from the ones we just described? What is abnormal? You can share on the use the message to just tell us what you think. What is abnormal, right? So Mukala has already said the first one is an ectopic. Yeah, certainly there's an ectopic beat which is interrupting. I will show people where the ectopic beat is. What about the second one? What's wrong with the second one? The second one. What is wrong with the second one? The heartbeat. You're busy doing your work, you want to do the heart rate, and this is what you are getting. The second one doesn't have the E and the A wave. Maybe, but I could argue that they are here. It's only that they are abnormal. What is abnormal? If I'm to tell you that these are the E and the A wave, what is abnormal about them? What is abnormal about the E and the A wave in this baby here? What is abnormal about the E and the A wave? Please, let's have takers. You are all scanning. What are you scanning? Let's have takers. Take your guess. If you get it right, you always remember it. Even if you get it wrong, you always remember it. So that when you are scanning, you say, oh, I once got this wrong. Now this is the correct thing. Let's have takers. I won't move from the slide until I have enough takers, until I see the thinking process of most people. What is wrong? Yeah, answers are coming. Let's see. There's only one person who is getting, who is in this talk. That is Mukala Asmund. So the E and the A wave ratio is almost 1. So there's an abnormal E and the A wave. Very good. You can see that the E wave is almost overtaking the A wave. Usually there's a problem on this heart. Yeah. In other parts, you can see here it's almost overtaking, and also the gap between them. What else is wrong? Which is obvious. Which I thought you guys would tell me first. Which I overemphasize on the normal heart rhythm. What else is wrong? What else is wrong on the heartbeat? Please, let's have a try from other people, not just from one person. Because you are all scanning and telling these women that, look, we've scanned you and your baby is fine. Track us for the regurgitation, not quite. We don't have it. We are all scanning and telling the women, look, your baby is fine. What is wrong with the baby's heartbeat? We have done a heartbeat, and these are the two heartbeats you got. Is there a sinus rhythm on this one, on the one to the left? Yes or no? Do we have a sinus rhythm on the heart to the picture to the left? Yes or no? Maybe we start with the rate. Is the rate normal? We want a yes or no. Is the heart rate normal? Since there are people in the meeting, let me call them out. Ishumba, do you think the heart rate is normal? Yes or no? Is it a sinus rhythm? When you look at it, is the heart rate normal? Yes or no? It's not a sinus rhythm. But let's see. 120, no, the 123 could be normal. Look, the baby is 36 plus 6, right? Don't forget the gestation. The baby is the baby's heart rate is normal there because this is almost a 37-week baby. So that is normal. So there is a sinus rhythm, but what Asmund said is correct, that we have some ectopic beats which are sort of interrupting the heartbeat. Like this one is not a normal beat because you don't see the normal biphasic flow, the E and the A wave as we see here. So these are the arterial followed by ventricle, arterial, ventricle. Here you can see that it's not a typical arterial. This is an ectopic beat because it's not biphasic, right? That's an ectopic beat there, which has failed to stimulate a good contraction, but it interrupts the normal flow now of the heart. You can see here almost arterial, ventricle. Now we are back to normal. Arterial, ventricle, arterial, ventricle, arterial, ventricle, arterial, ventricle. Another ectopic. There is an ectopic interrupting here again. An ectopic will excite the atrium because these are arterial ectopic beats, which we are seeing in this case. But an ectopic may not be strong enough to cause the ventricle to contract. This is why you see just a small waveform here. Then we have another arterial, we are back to normal arterial ventricle. Intermittent ectopics, as long as the heart rate is normal, do not harm the baby. They only harm the baby if they interfere with their heart rate. The intermittent ectopics, whether they are arterial or whether they are ventricular. As long as the overall heart rate is normal, then we are good. We go to the next. Let's see, somebody said something. Okay, privilege to say it's normal. Right, we go to this one. Without doing anything, we didn't change the speed here. So if we didn't change the speed, what it means is that this is a very slow heart. It's unfortunate we didn't put the heart rate in here, but this was a very slow heart. It was beating around 50 something beats per minute. You can see we do not have an arterial following ventricle. Look where the arterial contraction is actually in front of the ventricles here. So that means there is no sinus rhythm. There is a disconnection between the atria and the ventricles in the manner the heart is contracting. So what condition is this called? This is called a heart block, a complete heart block, whereby there is a total disconnection of the atrium contractions and the ventricular contraction. Others may ask and say, so if there is disconnection, how is the heart contracting? The ventricles, they have their own node called AV node, which beats automatically at a lower rate if there is no stimulation from the sinoatrial node. So even if we do not have communication from the sinoatrial node, which is found in the left atrium, right atrium, sorry, the AV node, it will be the origination of the contractions. The AV node beats at a very low pace of around 60 beats per minute. And it will beat in a regular way. This is what we see here. So if we were to do the heart rates of the two, we may see that they are actually different. The arterial and the ventricular rate, they will be different. So this is why we want you to be able to know that what you are calculating. In most cases, when you are doing the heart rate, we want you to calculate the ventricular rate, because the ventricular rate is the one that fills the heart rather than the arterial rate. It doesn't matter what rate the arterial is. If the ventricular rate is not in tune with the arterial, then the cardiac output will be reduced, because the ventricular outflow is the one that determines the cardiac output. So when you are doing the fetal heart rate, you want you to do the ventricular rate instead of the arterial rate. So please get this right. Let's continue. I may end just with the rhythm today, but I think we can do situs abnormalities. So situs abnormalities, what are we talking about? We are saying there are certain defects, cardiovascular system defects, that do affect the way the vessels are arranged in the baby. So you should always start scanning at the level of the tummy here. You can see the stomach and the heart. They are all on the same side of the baby. But before you can do that, first of all, make sure that you have established how the baby is lying, and you've identified the left shoulder of the baby. If you haven't identified the left shoulder of the baby, you cannot determine situs, because you could have dextrocardia, you could also have a stomach which is on the right side, and you may think everything is normal. So you can see here that here we are, the stomach and the heart on the left. On top of that, it's not enough to say you have seen the stomach and the heart on the left. You also have to see the aorta. This is the aorta here, and the inferior vena cava. The aorta should always be more towards the left, and the inferior vena cava more towards the right. This is the inferior vena cava there. Aorta is slightly to the left of the spine, which is here, and the inferior vena cava slightly to the right. That is very important. This is what is being depicted here by this image. So you can see that's the vertebra, that's the inferior vena cava, the liver, the portal vein, and portal sinus. Of course, that's the gallbladder, and this is the aorta, and the stomach bubble, and the spleen. The spleen is the same structure we see here behind the stomach. Here, that's the spleen. So this is very important to identify situs when you're examining the baby's heart. Some situs abnormalities. Do this play? I think this should play. Let's see. Sure, does this play as well? Let's see. Okay, it's only this one is played. Let's look at this heart now. At this image, what is wrong? Just on that image we are looking at there. I'm sorry, it's not the base of image, but there's something which is not right on that image when you look at it. What is wrong there? The clever one. You can start with the one on the left side. What's wrong with the two images? What is wrong with the two images? When you look at them, any takers, please take your guess. You remember it, even if you don't get it right. Any guess, what is wrong with the two images? Right, let's see, the answers are coming. Arch and abdomen on different sides. Which image, Dr. Hachayo? Because there are two, the right or the left? You mean this one, yes. So the one on the left, you are right to say the stomach, you can see the stomach there and the heart in the same plane. It is not normal. You can see that the heart is squashed to the wall. You have never seen the heart squashed to the rib like this. You can see it's squashed to the rib. There. This is the rib here, and the heart is squashed to the rib, and we have a stomach in the plane. A good guess, what condition is this one? A good guess. What condition do we have? Because you may, I think some of you have come across this, either you picked it or you missed it while you were scanning. What condition is it? Where you are going to see that the heart is squashed to the left, there's a stomach bubble in the thorax. What condition? A good guess. What condition do we have? This one should be easy. What condition is it? Let's see. Ectopic cordis. Nah. Ectopic cordis is outside the thorax. In this case, the heart is inside, guys. Since within the, you can see these are the ribs here. And that's the heart squashed close to the ribs. So the condition is a congenital diaphragmatic hernia. So the abdominal contents have herniated into the thorax, including the stomach and the bowels you see here. So this is a case of congenital diaphragmatic hernia, left-sided congenital diaphragmatic hernia. So it has pushed the heart to the left. In this image, we see the two vessels very close together there. Instead of seeing the inferior vena cava to the front, but there are two vessels which are close to the spine. One is on the left, the other one is on the right. You see these two vessels there? This is not normal. If you see two vessels close together when you are doing abdominal circumference, close to the spine like this, then this is not a normal baby. The condition we are having here is called interruption of the inferior vena cava with azygous vein continuation. So interruption of the inferior vena cava with azygous vein continuation. So this is the azygous vein. Azygous vein is more like, would I call it rudimentary vein? But when there are problems, it persists. For those who know embryology, it will persist, and it will be the one that will connect with the inferior vena cava up there to feed into the heart. So in this case, there is no inferior vena cava, but what is draining the lower part of the body is the azygous vein. We see this condition in heterotaxy. with left isomerism in heterotaxic conditions. So this is not normal. So remember this, because it's very important to be aware of this condition. Okay, so I think I'll end here today because it's almost 9 o'clock, and I think what we said is a lot on the truth. So what I would want to challenge you to do is, please, when you are checking the heartbeat today, do it in the right way and make it a habit to do it in the right way so that we can increase the detection rate of fetal arrhythmias, because we are not picking them enough. They are more common than we are picking them up. So let's try to do it in the right way. Put your caliper underneath the valves, the way it should be done. Zoom enough and put it underneath the valves, as you can see here, and as you can see here, close to the AV, to the intraventricular septum, so that you get this kind of tracings. If you don't get this kind of tracing, then there should be something which is not right there with the baby's heart, or you are not doing it right. So remember to do it right. Then also try to check the situs today to see if indeed you can get it right in terms of identifying the stomach and the heart on the same side, the inferior vena cava and the aorta on the same side. Otherwise, thank you so much, and enjoy the rest of the day and your weekend to come. Otherwise, bye-bye. I'll continue with the heart next week to just do the 4-chamber view and the great outflow tract. Bye-bye.